centrifusion in the test tube. It's separated into a main bulk of DNA and then fragments, microsatellite fragments of repetitive DNA that was floating on the surface. That's how they came up with the name microsatellite. Okay, so how DNA damage is repaired? DNA damage is repaired by mismatch repair proteins. Most commonly, they are MLH1, MSH2, MSH6, and PMS2. When DNA damage occurs, these mismatch proteins come and excise the incorrect segment of DNA, and then resynthesis of the DNA sequence using DNA polymerase occurs. When there is mutation or underexpression of these proteins, you can, of course, it makes sense. These errors are going to accumulate and there will be a lot of microsatellite instability. Lynch syndrome and microsatellite instability. So Lynch syndrome is a very interesting syndrome. It took a while to discover it. Typically, it was first discovered in colonic carcinoma. So it was called hereditary non-polyposis colorectal cancer syndrome. It's autosomal dominant, and usually when it's autosomal dominant and inherited, it's due to germline mutations of the genes responsible for the mismatch protein production. And because these mismatch proteins are not functioning as they should, these tumors have high levels of microsatellite instability. Lynch syndrome also can be sporadic. And it's in up to 15 to 20% of cases, the mutation is actually not inherited germline mutation. It's due to methylation of the MLH1 gene. When methylation happens, this inactivates the gene and results in loss of protein expression. And as I said before, Lynch syndrome is a colorectal cancer-dominated syndrome. However, in women, the story is different. In women, it's the sentinel cancer in more than 50% of cases, but endometrial cancer is more frequent in women with Lynch syndrome than colorectal cancer. 22% present at stage 2 or 3, so they present with advanced disease, and 14% are associated with high-grade histotypes. The risk of developing, so why is it important to detect Lynch syndrome? Because the patient goes to genetic counseling, and if there is Lynch syndrome and it's inherited, it's important for other family members to know that there is a possibility that they could have Lynch syndrome as well. Because 25% they present with known types of cancers, so the screening for these types of cancers would be more frequent in this population. And not only they present with colon and endometrial, just one type of cancer, 25% will present with another type of cancer 10 years after the diagnosis, and 50% by 15 years of diagnosis. So it is important because you would want to screen these patients more closely. The mean age of onset for colon cancer is for early 40s, for endometrial late 40s to early 50s. Okay, so how do we diagnose this in the lab? We have tissue testing in the form of immunohistochemistry. It's very convenient. You can use formalin-fixed paraffin-embedded tissues and commercially available antibodies. And you have the MSI analysis by PCR and the MLH1 methylation analysis. And I'll show you examples of that. So this is an example of immunohistochemistry for MLH1, PMS2. There are usually we do for 4, the MLH1, PMS2, MSH2 and MSH6. And typically it's a nuclear stain, any amount of staining is considered positive. So when you see positivity, you report it as this tumor has intact mismatch repair proteins, so it doesn't have any, it's unlikely that it has Lynch syndrome or microsatellite instability. This is an example of the tumor that has loss of expression of MLH1 and PMS2. And one other thing I wanted to mention is that MLH1 and PMS2, they work in pairs. So if MLH1 gets lost, PMS2 automatically gets lost, but not vice versa. If PMS2 gets lost, doesn't mean MLH1 not necessarily is going to be lost. The same thing goes for MSH2 and MSH6. If MSH2 is lost, automatically MSH6 is going to be lost as well. And these are just examples of how we report in our lab. So the result would say loss of immunohistochemical expression of DNA mismatch repair protein MLH1 and PMS2 in adenocarcinoma, and this pattern can be seen in Lynch syndrome or in sporadic tumors due to somatic methylation of MLH1 promoter. And reflexly, if there is loss of MLH1 by immunohistochemistry, we reflex the sample for MLH1 hypermethylation testing. And this is how we report, if it's present, MLH1 hypermethylation present, then we say this is most likely due to somatic or epigenetic inactivation of MLH1 rather than inherited germline mutations. No. So these are the most commonly mismatch repair proteins that get. So if okay, so if MLH1 is lost, equal or there is a difference, and especially if you select a treatment here, it's very important so that that therapy will give it to this patient. So you're saying why does he perform the 4? Why perform the 4? And if there is any difference between if the loss occurs in S1 or S2 or... That's a really good question, because if the loss occurs specifically in PMS2 or MSH6, that's more commonly associated with Lynch. But if the loss is in MLH1, then it could be sporadic or it could be Lynch. We have to do the 4, yes.
So, excuse me, if suspected Lynch, so the patient subject for follow-up regimen or something like that?
Yes, so they would go for genetic counseling and their family members would go for genetic testing, and they would be subject for very close screening for colon cancer, for example. And then there is another way to test for MSI analysis, which is PCR based. So what I have shown so far is immunohistochemical techniques to test for mismatch repair protein loss, but there is also PCR based techniques. So 7 markers, 7 microsatellite markers. There are a lot of microsatellite markers in the human genome. These markers are the ones that are chosen by the National Cancer Institute to use for microsatellite detection, instability detection. And also these are commonly used in parental testing, because the pattern that these markers show allelic shift is very unique to each individual. And of course, if we want to see the pattern between the mother and the child, the father and the child, it's usually the same. For MSI, to call it high, you have allelic shift in at least 3 of these markers, and I'll show you how it looks like. For a stable microsatellite stable tumor, you will not see any allelic shift in all 7 markers. If you see only in 1 or 2, then it's an MSI low. And MSI-low tumors, the clinical significance is not that very well defined, and they are not associated with, as much associated with Lynch syndrome. So here is a DNA tracing of 2 examples of the microsatellite markers. And at the very top, this is from normal tissue. This is where that marker falls on this DNA tracing. And you can see in the tumor, underneath the first one, you can see that there is allelic shift in the focus of that marker. That means there's a lot of gain of microsatellites in this focus. That means that this tumor has microsatellite instability. Here's also another example, normal for another marker, and you can see the tumor has a lot of gains. That means that this tumor has a lot of allelic shifts, or in other words, has a lot of microsatellite instability. This is an example of a report of MLH1 methylation analysis, and again, the very top is from normal tissue. So the idea of MLH1 methylation analysis is that we add bisulfite. Bisulfite should change cytosine to uracil, but methylated cytosine is resistant to this effect. So what happens if there is methylation, the DNA will fall at a different location in the DNA tracing. So the first tracing is from normal tissue, where there is from a tumor that doesn't have MLH1 methylation. And the second tracing is from a positive control, a tumor that has MLH1 methylation. See, they have different location on the DNA tracing. And then the one in the bottom is from the tumor. And clearly you can see the tumor has both methylated and unmethylated, but the unmethylated is usually from contaminating stromal cells or other benign cells nearby. Okay, and then I'll have a few words about the pathologic features of MSI-high endometrial carcinoma. There are pathologic features that can make you suspicious that this patient could have Lynch syndrome or a sporadic Lynch syndrome. So if it's Lynch syndrome, the endometrioid and non-endometrioid types can both occur in Lynch syndrome. And all tumors with non-endometrioid histology usually occur in patients with MSH2 mutations. And that again goes back to your question why we have to perform the 4. Typically, these tumors have high nuclear grade. There is a lot of squamous metaplasia. They have deeper, more aggressive features like deeper myometrial invasion, lymphatic vascular invasion, extrauterine spread, and characteristically, they have high numbers of tumor-infiltrating lymphocytes. The same thing happens with colon carcinoma. They have also high colon carcinoma with Lynch syndrome. They have high number of tumor-infiltrating lymphocytes. And usually it arises in the lower uterine segment. And so here are histologic pictures. The one on top, you see the tumor nest surrounded by lymphocytes, and this picture over here on the left-hand side has high grade, like a lot of solid areas, more than 50% of the tumor was solid, and frequently we have squamous metaplasia. And this is my final slide. It's about endometrial carcinoma that is MSI-high arising in the lower uterine segment. These tumors are less common than endometrial carcinomas arising in the uterine corpus, about 3.5% of endometrial carcinomas. They usually present in significantly younger females, 54 compared to the uterine corpus carcinoma arising in 63 years old. These tumors, not the majority, but a big percentage of these tumors, 34%, are MSI high. 28.6% of those 34% are confirmed by PCR testing that they have Lynch syndrome. So if you get a tumor that is located, the main bulk, the epicenter of the tumor is in the lower uterine segment, that's another clue to suspect that this patient, especially if it's a young patient, that this patient has Lynch syndrome, and so you test for the mismatch repair proteins. And that concludes my lecture.
May I ask you something in relation to the synchronous tumors, or a tumor may be diagnosed and later by a few years the endometrial tumors appear. There is any possibility of being a metastasizing process in these conditions? Process from the colon to the endometrium or the reverse, or they are two separate tumors arising on the same background of the genetic predisposition?
It differs as a case by case. So, for example, if the patient, you're saying like the patient had colonic carcinoma and 5 years later develops another colonic carcinoma.
Develop endometrial carcinoma.
Endometrial carcinoma. So I think if it's, that means that most likely they are two different primaries, the endometrial carcinoma. And then if you're suspecting that this is recurrence of metastatic colon carcinoma, you can use immunohistochemical markers.
To separate
it, yes.
Different type of cytokeratin, for example.
And CDX2. Yeah. There is also another stain, it's called SAT-B2, that's also specific for gastrointestinal origin. That's commonly used, SAT-B2.
In cases of colonic carcinoma and endometrial carcinoma, in the same patient, they will have the same microcyte stability in both tumors, or it may differ also?
They will have both. Yeah, they will have both when you show the microcyte, especially if it's inherited. Yeah. Yes. So MSI, immunohistochemistry does not really, we cannot use it to quantify whether there is the MSI high or MSI low or stable. Immunohistochemistry basically tells you there is loss of protein expression. After you detect that there is loss of protein expression, you send the sample for PCR analysis, and then it can tell. But some labs, because it's expensive, the PCR analysis is expensive, we just do the immunohistochemistry, and then the patient, we just do the immunohistochemistry and the hypermethylation test. Because remember, if it's hypermethylated, it's sporadic and not inherited. So it's important to know if this patient has a sporadic Lynch or inherited because of her children, for example, or other family members.
Mm-hmm.
Yes?
In your experience, what is the possible immunostaining panel to differentiate between primary peritoneal carcinoma and ovarian carcinoma? Because sometimes you receive a specimen without any history or even no ovarian mass, but you should consider such two differential diagnoses, primary peritoneal carcinoma and ovarian cancer.
Yeah, this I agree with. I feel your pain because this is a very common problem, and it's impossible.
Really?
It's impossible to tell for sure. We rely on the bulk of the tumor, where the bulk of the tumor is. But, well, actually, there's a theory that says for serous carcinoma, especially in the gynecologic, the peritoneum and the ovary, that it's a multi-centric, like it's the same tumor, but it arises in the, but we cannot really differentiate. We just depend on the size and where it's located.
Thank you very much, Professor.
Thank you for having me
in the lecture.
Thank you.
And I would like to announce to the audience that we will start the site seminar immediately.